Good evening, everyone. I'm Rajiv Kulkarni. Thank you for the opportunity to the organizers and respected seniors and my dear friend. Today, my case is heterotopic ossification post TKR surgery. So I had this 74-year-old lady with a height of 162 centimeters, weight 59 kgs, with a BMI of 22.5. Uh, she was walking with walker support and she was needing assistance while ambulation. Uh, she complains of bilateral knee pain, right more than left knee since last 2 years, and which aggravated since past 3 months. She had severe difficulties in activities of daily living, such as squatting, climbing stairs, and doing daily chores. She was diabetic with a controlled. She was not on insulin, and her HbA1c levels were 6.8. Hypertension was controlled, and osteoporosis was diagnosed with a DEXA scan of a score of 2.1, for which she was on the injection of teriparatide 20 micrograms since June 2024. On physical examination, she had a waddling gait with a dorsolumbar kyphosis without neurodeficit. And in terms of knee, she had bilateral varus deformity of 20 degrees, which was not correctable. Range of motion was 0 to 120 degrees on both the knees. Patellofemoral crepitus was present. Active SLR was present with a quadriceps and hamstring strength of 5 by 5. Distal pulsations were palpable, both dorsalis pedis and posterior tibial. These are the these are the post-operative X-rays, pre-operative X-rays. Uh, I couldn't do the scanogram because she was stooped because of dorsolumbar kyphosis, and she was needing a walker support for even for managing few steps. So standing X-rays were done with right more than left knee, which was more painful. These were the X-rays for the spine, and MRI also revealed no neurodeficit, no posterior cord compression. After anesthesia fitness, she was taken up for the surgery, which was a single stage. Right was more painful, so we proceeded with right, which was done on 27th of January this year. Conventional tourniquet was applied for which the time was 65 minutes. Posterior stabilized knee was done. Femur being size E, tibia was size 3, and poly 10 mm. Palacos and pulse lavage along with periarticular injection was done. Post-operative period was uneventful. She was mobilized full bed bearing with walker with a physio support on the same day of the surgery in the evening, and she was comfortable. Vitally, also she was all fine. Post-operative knee range of motion at the time of suture removal was 0 to 110 degrees. Uh, and these are the post-operative X-rays. On the right-hand side, we can see the component is well aligned. No notching is there. Surgical technique was standard, uh, conventional. Although I still, if I foresee retrospectively, the cement in the tibial keel was a bit more. But yeah, that is what I can assess my post-operative X-ray right now. This was the post-operative X-ray at the second month post-op, which was taken in March 2024. And there I started noticing the anterior aspect of the femur, some calcification, and with a gradual progressive reduction of range of motion from 110 degrees to 90 degrees. And she was complaining of some sensation of hardness over the anterior aspect of quadriceps. Surgical site was uneventful, wound was healed with the primary intention. And this was the X-ray taken in the month of April, 1 month apart. And we could notice gradual maturation of calcific foci on the anterior aspect of distal femur, which is fortunately way away from the component, but it was in the intermedius plane of quadriceps. And this is the post-operative recent X-ray taken in the month of July this year, and where we can appreciate some maturation of the heterotrophic ossification on the anterior aspect of distal femur, along some speckled calcification on the superficial quadriceps muscles. This calcification is adherent to the anterior cortex of the femur, but currently the range of motion is 0 to 90 degrees. This is her video which was sent by the patient over the weekend, last weekend, and we can see some amount of flexion deformity is there. Some not flexion deformity, but some amount of residual flexion is there. Complete extension is not possible. And this is her walking video. She's able to walk without walker and currently asymptomatic with the knee. And I did some review of literature and then found a couple of articles mentioning these uh, this complication post knee replacement. Basically, a heterotopic ossification is a lamellar bone forming between the periarticular soft tissues after surgery or a trauma. And it forms around the knee joint, which mostly develops at the distal femur and sometimes within the quadriceps and patella soft tissues. It typically matures and starts getting visible by the 3 to 6 weeks, and then matures at the end of 6 months. This was one article from Journal of AAOS published in 2021, which was a systematic review conducted in 2,988 knee replacement. And they mentioned that incidence of HO with a lower rate of 5% in most of the cases. So there is a classification also mentioned by Furia and Pellegrini in the Journal of Arthroplasty 1985, in which they have categorized HO post-primary knee replacement into 1A, 1B, wherein we have island of bone in the suprapatellar soft tissue, which is more than 5 centimeters, if it would be 1B. If it is less than 5 centimeters, it would be 1A. And 2A, 2B would be ossification contiguous to the anterior femur cortex. So, which in my case, it is 2B, which seems more than 5 centimeters, and it is contiguous to the anterior surface of the distal femur cortex. Routine prophylaxis for primary TKA in this routine prophylaxis for HO is not supported by any literature. Hence, there is a paucity of literature in this case, as this is one of the rare complications. Management strategy lies is mostly it is observation and rehab. It is to maintain the rehab and rehab range of motion. 90-degree is the expected. More than 90 in this case would be a bonus, but at the cost of longevity of the implant and the bone quality. Majority are radiographic only and they do not affect the outcomes. One of the most important goal is to maintain the gentle range of motion and quadriceps function during maturation. If the situation is symptomatic, that is painful snapping, patella maltracking, and significant range of motion loss, then we have to ensure there is a good maturity of the heterotrophic ossification, which is stable margins on serial X-rays, and which occurs typically at the end of more than 6 to 12 months from the date of onset. And we have to rule out other causes of stiffness, that is arthrofibrosis, component malpositioning, and infection. Current intervention options mentioned in this article, which was published in Nature in 2024, suggests arthroscopic or open debridement or excision of heterotrophic ossification impinging the extensor mechanism or the suprapatellar pouch. And these are my references for the case. Thank you, and I would like to open this case for discussion.
Yeah, nice case, Rajiv. But yeah, the only thing is, I think everything went on well. So patient is asymptomatic, and I think needs no further management.
Yes,
But
sir.
the literature you quoted says about 5%. I'm not sure. I have not seen my own TKR developed HO or seen where institutes I worked. This is
Yes.
probably one of the first cases that I am seeing with the HO after a TKR. So 5% looks like a very high figure.
Yes.
I
Yes.
don't know if
Yes.
others have seen it.
Yes, sir. Yes.
Arun, can I add?
Yeah, sure.
Arun?
Yeah.
Yeah, I'm Dr. Raghurandan.
Yes, sir.
Rajiv, just I would like to know from you.
Yes, sir.
What this patient has developed HO, because
Yes.
it's extremely rare in your practice as well.
Yes.
And as Dr. Arun mentioned that we have not encountered so far in our practice as well, after so many knee replacements. Why do you think this happened in your case, in this particular case? Any idea?
Sir, retrospectively, I try to answer this question. There are a couple of possibilities, probably a hematoma. I didn't put the drain in this case, but couple of knee replacement I have done. I have never deviated from the standard practice. I don't put drain. I use the pulse lavage. Quadriceps is closed by me. Single layer quadriceps sutures, continuous and then uninterrupted. But then in this case, I feel it would have been a hematoma, which would have resolved over the period of time. And I
Okay.
also
Can you go back to your immediate post-op X-ray?
this, yes. Yes.
Okay, just one. So I can see just a small thing to be added. I can see
Yes.
the skin clips extending further up, proximally, almost to the
Yes.
distal mid-femur. I don't know
Yes.
whether the same dissection was carried out throughout the length of the skin incision.
Yes.
Probably, I think why it could have happened in this case is probably you would have breached the suprapatellar pouch, So when you extend it, I don't know, you are the surgeon, you have to enlighten
Yes.
me.
Yes.
So
Yes.
that's the reason, along with aggressive superior elevation of the whole fat pad from the trochlear edge,
Yes.
proximally when you violate the suprapatellar pouch, where you don't need to do that, but I don't know
Okay.
what you have to
Yeah.
clear
Yeah.
sure
Yes.
about that.
Yes.
So
Yes.
that could be the reason, along with the muscle bleed, with the superior elevation, with violating the suprapatellar pouch. That could be
Yes.
one of the reasons why this has happened. Because you see, there is some amount of ossification within the muscle as well.
Yes.
So
Yes.
yeah, so there's more injury to the muscle groups along with all the above mentioned factors could have been the reason. I don't know.
True. I agree with that. Yes, it did happen. I wanted a exposure. So yes, you are right. Actually, I didn't notice these things, but yes, not extensive superior elevation, but suprapatellar pouch. Yes, was incised, and yes, and then the skin incision, whatever the skin clips, we can see that was the extent of quadriceps also.
Okay. So probably I think you can take that as a point, and try to be a little more conservative.
Yes, yes, yes. Thank you, sir. Thank you so much.
Thank you.
Any prophylactic indomethacin or radiotherapy like that, will it be useful in this cases? Did you try anything stopping the teriparatide like that?
I did discuss this with endocrinologist, and they also mentioned that teriparatide per se is used for osteoporosis. It does not have any effect on extra osseous bone formation or any calcific bone formations elsewhere. So in view of this, we interrupted teriparatide for 2 months, but then it doesn't have any mention in any literature that role of teriparatide in incidences of heterotrophic ossification.
So anything like indomethacin or radiotherapy like that, is it quoted in the literature? Anything for the treatment?
It is quoted. It is quoted 4 to 7 grays of radiation is mentioned in the literature for this heterotrophic ossification. But initial management is if the range of motion, we have to wait for the heterotrophic ossification to mature. Now the patient is in 6th month of follow-up. We operated her on 27th of Jan. Now today is end of last week.
Sorry to interrupt.
Yes, sir.
Yeah, see, prophylactic radiation or indomethacin is helpful only in the initial period after surgery. Once you've seen a heterotopic ossification at 6 weeks after surgery, there is no role for a prophylactic indomethacin or radiotherapy at that stage. So radiotherapy is generally given within the first 24 to 48 hours. Earlier, they used to give for some hips. So I've been part of some hips where they give prophylactic radiation, but that was given 24 to 48 hours after the initial surgery. If you give it like 3 to 6 weeks after the initial surgery, there is no use of radiotherapy. So that stage where you have seen it, and luckily it has not. So at that stage there is no role for indomethacin or radiotherapy to clear that for what Mithun is asking.
Yes.
Okay.
Yes.
Done.
Yes. Okay. Thank you, sir. Thank you.
And then will it improve the, it might be the reason for extensor lag, no, sir? Some calcification might be.
Yes. There is some that explains the extensor lag, which is around 10 degrees. Yes.
Yeah, but considering the amount of ossification that has happened, I think she has a fairly good function. So I think we should all be happy with that.
Sure.
It's quite common to see some degree of heterotopic ossification around the hip, particularly. And however careful you are, you have to be careful that you don't injure the muscle, because it's the muscle bleed that leads to the heterotopic. But heterotopic calcification versus heterotopic ossification is a little bit of a hair splitting almost. But if you get hematoma formation, then that's supposed to be ossification. So here, I mean, one of the things I could, because you generally, the physiotherapists, they're quite aggressive with getting range of movement. And I don't know whether, I mean, that certainly applies to the elbow, but in the case of the knee, though people are generally aggressive and, or say, the same day surgery, they're walking up steps and all that is quite sort of standard fare. But, if you start bending the knee early also, that also might contribute to some more trauma to the muscle and formation of sort of myositis getting calcified.
True, sir. Yes.
Arun, shall I say something, Arun?
Sure, sir.
Hello.
Yeah.
Arun, we have seen a few cases, 4 to 5 cases of heterotopic ossification in a huge volume. I know when I was working in Shalby. But what we correlated is, as Dr. Raghunandan was saying, the more you dissect more proximally, when we size the femur on the lateral cortex, so we tend to remove the synovial fat to flush the stylus exactly on the cortex, so underlateral cortex. So we tend to remove the thick synovial pad of fat. So we restrict ourselves. The more we resect completely as proximal as possible, removing the entire synovium, the high chance of you elevate the periosteum, there is some kind of a bleeder can be there in the subperiosteal regions, which may later lead to formation of the bone. So whereas on contrary, when we, for a debridement case, we go an extensive debridement. We remove the entire periosteum, all the synovectomies, but we have not found any kind of heterotopic ossifications when we go for an debridement in an infective case. When we do an extensive debridement as proximal as possible. But in a primary knee, I think we have seen around, to my knowledge, I think around 5 cases. Minimal to all these grades. More we dissect proximally, more we remove the synovial the pad of fat from the anterior aspect of the femur, this chances of heterotopic ossification is high. But 4 to 5%, I don't think so. That number is.
But they probably include all these fuzzy bits of calcium deposits that you see around the medial and lateral sides of the knee also. If you include those bits also as heterotopic,
Yes, sir.
then it could go up to 5% because.
Sir, we can see some heterotopic ossification along the MCL borders. Sometimes we just remove only the osteophytes. We are some tenting osteophytes. We just tend to remove the osteophytes from the medial aspect of the tibia. So we don't completely nibble it off because they are completely into the MCL. In the fear, we might just nibble it. So those kind of shattered bones can form a thickened heterotopic ossifications on the medial sides along the MCL sides. If including all those numbers,
yeah, then it could go up to 5.
5. I mean, particularly suprapatellar pouch and this kind of heterotopic ossification, I don't think it's very, very rare.
Point.
The point of, I mean, I've seen people who, with the mobile bearing, for example, the LCS, you basically just take the diathermy and go along the articular margin of the femur with the cartilage and the bone. You don't actually lift it up. You just sort of slide a part of it which goes under. So you're not opening the suprapatellar pouch technically. But it's quite common to see people sort of, take a periosteum elevator and sort of push that tissue back. So if you're opening up the periosteal sleeve also, then this kind of bone formation could get a boost. The other thing not to discount is the physiotherapist role, because physiotherapists are also quite keen on, they like doing these little massages also.
Yes, sir. Massages also may contribute, sir.
Yeah.
Sir, it's 9:30, I think, sir. We'll skip to the next session. Thanks
Yes.
for a nice presentation, Rajiv.
Thank you. Thank you for the opportunity, sir.
Okay.
And thank you, Raghunathan, sir, for valuable insights. I would definitely take it.
We will routinely limit the skin incision
Yes.
but above the patella.
Yes.
Matter.
I would follow that.